I'm Dr. Sabrina Siegel with the Neuroscience Education Institute. Welcome to the NEI podcast. On this show, I sit down with renowned mental health care experts from a range of diverse backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions. Welcome to this episode of the NEI podcast. In this episode, we are at the 2021 NEI Congress, and I'm so excited to have here with me today Dr. Charles Scott. And Dr. Scott just finished an incredible presentation titled Cannabis and Violence from High to Homicidal. In this episode, you will get the chance to have some of your unanswered questions addressed by Dr. Scott. Welcome, Dr. Scott.
Oh, thank you very much for having me. It's a pleasure to be here.
Absolutely. Our first question comes from someone in the audience who asked, can you speak to the new push of legal sales of Delta-8 THC as a replacement for marijuana use? Is there research regarding the psychosis risk with this compound as compared to Delta-9 THC?
Yeah, I'm happy to address that. What I think may be important is to first just review what is Delta-8 compared to Delta-9. And so in my lecture, you heard me mention that the cannabis plant has over 100 different types of cannabinoids, and these are products in the plant that affect the body. And I talked in the presentation about the two most common ones that occur in higher amounts, and that was CBD and THC.
Right.
But there are other minor cannabinoids that occur in a lot less amount. And one of those is Delta-8 tetrahydrocannabinol, also known as Delta-8. So it was actually discovered in 1965 by the father of cannabis. His name was Dr. Raphael Mechoulam. And it's a minor cannabinoid, but it can still be intoxicating and make you high. And it's because it acts on the same receptor that Delta-9 does. Again, that's that CB1 receptor.
Right.
And one of the key differences compared to Delta-9 is there's less of it in the plant, so it may be harder to get the higher concentrations. So in that setting, it may not get you as high, but it can have a high associated with it. Now, on the issue of its legal status, it is sort of in a gray zone right now. You can find it on stores or online, even though the FDA has said that it's illegal to add it to food or to sell it as a dietary supplement. So right now, I think it is a gray zone legally as far as how that stands, but it can be purchased online. Now, again, when you're looking at the effects of it, many are similar to THC or Delta-9, but there's much fewer side effects or warnings that have been actually published to date. The common ones that do occur are ones that you would see with Delta-9 THC, so that's dry mouth, red eyes, paranoia, feeling hungry, nausea and vomiting, anxiety, and a faster heart rate. Regarding the relationship of Delta-H to psychosis, the studies that I have looked at to date and that I presented today were not examining the Delta-8 compound. So I think that's also to be determined. And remember, it's in much less concentrations typically than what the Delta-9 THC would be. So I hope that answers that question.
Right. Thank you for that answer. The next question is, are there recommended CBD THC ratios for safety and efficacy?
Right. So you'll see, first of all, the patients that you're treating will likely tell you, if you ask them, what CBD THC ratios work well for them. I had a client I was evaluating, for example, last week, and he noted very big differences between a 1-to-1 ratio of CBD to THC versus pure THC versus pure CBD. What I think as far as your job as a psychiatrist is, though, the higher the concentration of THC to CBD, and you would ask for that ratio, the greater the risk of the adverse effects of THC. Remember, CBD is an antagonist at the CB1 receptor. And so it can help negate some of the potential adverse effects or the high of THC as well. So in my opinion, you're looking at a ratio where CBD would be somewhat higher even than THC, or at least 1-to-1. To date, I haven't seen much well-published literature on if there is a particular or a standard or a fixed ratio. So I think it's going to be dependent on your client. Again, my thumbnail advice would be the higher the CBD to THC ratio, the better.
Got it. The next question is, what causes psychosis from synthetic cannabinoids? That was really fascinating.
Yeah, and it's very frightening, the impact of the synthetic cannabinoids. I think the thinking is just its overwhelming effect and how intense it is on the CB1 receptor, and that level of negative reaction and intense reaction with the CB1 receptor is one component. But again, these are sort of newly emerging compounds, and I think there's a lot of work left to be done on that. I actually now, though, recognize if I'm walking down the streets, I live in San Francisco, and I can see people who have that kind of zombie bent over effect screaming. And, you can almost visually recognize now people who are likely using a synthetic cannabinoid. So currently the findings are that it does act on CB1, and that may be its primary area of action.
Wow. This next person says, I often see patients that are using cannabis regularly, but they continue to present with moderate to severe depressive, anxiety, and trauma symptoms and don't see the connection that cannabis is not helping them. How would you approach these patients?
Yeah, I think you could take 2 or 3 key steps. One is just in a non-judgmental way, start to educate them about the actual research or literature on the relationship in some individuals of THC to psychosis, to mood disorders. I think it's always fair to recognize that maybe the majority of people who use THC will not develop a mental disorder or depression. And it's going to depend on your patient's frequency of use, type of use, form of use, potency, and educating them about that. The other thing you can do is just work with them and establish even baseline anxiety scores, depression scores through commonly administered instruments, and have it become apparent to them if they're continuing to use THC, if there's either no improvement in their depressive and anxiety symptoms or worsening, so that just the evidence is the evidence. And so you're working kind of as a coach or someone educating them and helping them along the way versus sort of a punitive or judgmental approach. Oftentimes that turns off clients.
Right, right. The next question is, what is the best toxicology screen to use to determine cannabis use if recently used, if CBD versus THC was used, and if the patient may be reusing? And then connected to this question, is it true if exercising will increase the results?
Okay, so I'm going to take the last question first because I think I have a little bit more information on that. So some of the byproducts of your cannabis, the THC, are stored in the fat cells. So you can have a person, particularly let's say if someone may be overweight for their appropriate size or BMI, and they've been using cannabis, but they want to get on a do right health kick. And so they say, I'm going to stop using cannabis and I'm going to really exercise and lose weight. And so they do lose weight. They lose 10 pounds, 20 pounds. And so they are breaking down their fat. You can have positive urine drug screens in a weight loss program if the THC stored in the adipose tissue is broken down and then released and tested in the urine. So it is possible that a person may have stopped using THC, but nevertheless have a positive urine drug screen. And so you would just need to work to explain that with them, not necessarily don't believe that they've stopped THC if they come up with a positive, and just be aware that is possible to happen. Right. The other part, I'm trying to remember the question. It was like, are there particular lab tests that may be either sensitive or one would recommend? And I'm just going to go over some key guidelines of the body fluids where we can test cannabis. And so it can be tested in both the blood and in the saliva, but usually the detection time is only for a few hours. So you're not going to have high yield using that testing methodology. For urine test, which overall are the most commonly used tests. You can have, if they've had frequent or one-time use, some people may have marijuana detected up to 13 days, but it can be much less than that. For a regular user, up to 45 days. And for heavy use, even after stopping use, if they're a heavy user, such as a daily user, high amount, you can have detection up to 90 days. Similarly,
Oh.
if you look at hair analysis, which is another form, you can have the byproducts of cannabis tested up to 90 days. So in some programs, they may do a hair analysis. When you're doing a hair analysis, your hair grows at about one inch a month,
Mhm.
approximately. And so the closer uh, the hair that is cut is to the scalp or the hair follicle, that's going to represent more recent use, and obviously towards the end of the strand, more distant use. So sometimes people try to analyze when their uses were through these sort of hair strand analysis. Again, remember that the synthetic cannabinoids are very hard to test in any way whatsoever. So that would be my overall kind of comment on that question.
Okay, that's excellent. The next question is, now Delta 8 is found in convenience stores. Is there danger with this like K2?
Well, we talked about this earlier. The difference between Delta 8 and K2 is that Delta 8 is a natural component naturally found in the cannabis plant. It's one of the over 100 compounds there. In contrast, K2 is a synthetic cannabinoid, and it has much higher toxicity. And as we talked about earlier in the podcast, the Delta 8 usually has a much lower potency, is similar to Delta 9, but is probably less potent due to its less concentration in the plant. But since it is newer and it's coming out, I think future studies will start to look at, does it have the same relationship as Delta 9? My thinking would be, since it's so similar, though maybe just at a lower potency, it may have similar effects, though somewhat attenuated, but if they were able to concentrate it out more, perhaps it will get to the same risk as Delta THC9.
The next question, is it safe to prescribe an antipsychotic to an individual with possible drug-induced psychosis?
Right. So that's a broad question, and I think it's going to depend on which drug has caused the psychosis. So depending on what drug they're having, you may have to choose, because of the combination risk of side effects, which antipsychotic you would use. If, however, you have someone with a cannabis-induced psychosis, as we were talking about in the lecture earlier, then if they do present psychotic, paranoid, hearing voices, then and they don't calm down, then you can go ahead and use a trial in an emergency setting with an antipsychotic. And I'm not aware of like significant adverse risk with cannabis and using that, unlike some other drugs. So that can be used in the emergency room setting if someone has extreme panic, anxiety, psychosis, and you're concerned about danger to self or others.
Okay, so our final question today is, if a patient is taking an SSRI and discloses later that they use marijuana weekly, is it okay to continue the medication?
Is it okay to continue the medication? So again, this always depends on the context of your patient. So let's say if the SSRI was significantly helpful in managing their depression or suicidality or severe anxiety, and the risk of having adverse effects from either withdrawing from the SSRI or having a relapse of mental illness, that risk could potentially outweigh the benefits of coming off of it with the additional cannabis use if they're smoking. What I would do is, again, review with them the risk of the continued cannabis use, see if it's caused any adverse, and document any adverse side effects, if at all, they're reporting from the cannabis use. Document what type of cannabis they're using, what CBD THC ratio, the frequency of the use. And if they start to have more of the risk factors that I outlined in the lecture, then that may sway you one way or the other, whether or not it's safe to continue. Remember, of course, if you suddenly stop an SSRI, you also have the risk of a potential withdrawal syndrome. So I wouldn't recommend a sudden cessation of the SSRI unless there's a clear clinical indication emergent to do so. The other thing is the DSM-5 added, as you may know, a cannabis withdrawal syndrome as well. So if a person decides to come off cannabis, then you should educate them about the DSM-5 symptoms of a cannabis withdrawal syndrome. Maybe you taper that off slowly with them so that they don't misinterpret an emerging feelings of depression, despair, dysthymia as due to, the marijuana that they say would help them. No, it may be that you're actually having withdrawal symptoms from the cannabis. And so a lot of times, for example, when people go and they may be incarcerated or into a setting where they can't use cannabis, they may be misdiagnosed with an emerging depression, which is more consistent with a cannabis withdrawal syndrome. So just go over those criteria when you're doing your evaluation.
Excellent. Thank you so much for joining us today and for getting to give our attendees a chance to get those unanswered questions addressed. Thank you so much, Dr. Scott.
My pleasure, and I wish everyone a great rest of the conference.
Thank you so much for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.